Good evening and welcome to our webinar series, which are being conducted every Wednesday without fail. And today too, we have a very, very interesting case discussion of an elderly person for bilateral total hip replacement. And moderators are very experienced seniors and very senior members of our ICA, Dr. Manjula Sarkar. Before I really talk about much more about our ICA, what I'd like to tell you is that the Indian College of Anesthesiologists annual conference is being held in the city of Lucknow this year, and this is going to be the 5th international and 15th national conference of the Indian College of Anesthesiologists. And this is going to be, as I said, in Lucknow, which is the capital city of Uttar Pradesh. It is from the 12th to the 15th September of this year, 2024. So please note this in your diaries, 12th to 15th September. They have a very excellent program that is being made, with starting with the workshops and then the lectures, the panel discussions, the orations. So this will be, of course, the ICM members know how successful these conferences have been, but I request the seniors to ask their students to also enroll at this time so that they can benefit from the early bird membership and early bird registration. And you can actually see the details of this conference on the website, which is www.icacon2024.in. Please note that down, or also at the www.anesthesiacollege.in. So on both these, you will get this special early bird offer. We have a combo offer, and we have a modified, and we have reduced the rates or made it very attractive for the students and the other delegates who are going to register for this. So it is my earnest request that please book your dates and do join this conference. That would be very interesting. In addition, we are going to be starting a PG assembly, a unified PG assembly under the aegis of the Indian College of Anesthesiologists. This is going to be held in New Delhi in the month of July 27 to 30th. So again, details will be given. Please save these dates, and the seniors, please try that your students can attend this. It's going to be very extensive by experienced faculty who will be having a good preparation for the students who are exam going. So coming back today, we have our case discussion. So Manjula, I think I should request you to start this webinar with the with your panelists, please. Thank you so much.
I thank Madam Sood for giving me this opportunity to hold this webinar today. And we have the all esteemed faculty with us, that their first slide will be projected during their introduction. And first panelist of this webinar is Dr. Pratibha Jain Shah. She is heading the department at RAIPUR Medical College. Then second panelist, we have Dr. Raghubir Singh Gedhoo. He doesn't need any introduction. Everybody knows him very well. So, and he has undergone a knee joint replacement recently, 2 weeks ago. So he will be the best person to talk about the joint replacement things on this webinar. Then third speaker of this webinar is Dr. Pallavi Waghalkar. She is assistant professor at KM Medical College, GS Medical College, Mumbai. Then fourth panelist, Dr. Yogita Jain, Yogita Patil. She is also assistant additional professor at St. GS Medical College, Navi, Mumbai. So I am sure that they are going to do the justice to this topic, and we are going to get the benefit about the discussion on this topic. So without delay, I'm going to start the discussion. The case allotted to us for this discussion is a 74-year-old lady, menopausal lady, has come to us for bilateral hip replacement. Her ejection fraction is 34%. She is a geriatric patient. And we have to follow this case in the points of acceptance of the patient, whether we should take this patient for surgery and anesthesia or not, whether to be done in a single stage or in multiple stages, what are the necessary investigations we have to undergo, how to optimize the patient by physiological mean, pharmacological mean, and psychological means. Then what should be the choice of anesthesia? What are the hazards of cement intraoperatively? List of steroid, use of steroid, whether we should consider or not. Then possible cardiac and pulmonary complications. Then what should be the pain management and the role of post-operative physiotherapy? How to take the cognitive care in this case? So this first question of mine is going to Dr. Pratibha. Dr. Pratibha, I would like to ask you whether we should take this patient for anesthesia or not. And if we have decided to give anesthesia, then what are the precautions we are supposed to take? So what is the risk in this case? Dr. Pratibha.
Yeah, thank you, madam. Good evening, everyone. Thank you all the stakeholders of ICA and senior members, especially Sood madam, Radhakrishnan sir, Manjula madam, Gedhoo sir, and for giving me this opportunity to be a part of this webinar. As we are seeing day to day, the number of patients with the elderly age and low ejection fractions presenting for orthopedic surgery, for THR especially, continue to rise due to increasing in lifespan. And being an anesthesiologist, we have to provide a quality and safe care to these patients in operative theater. So our patient, as you said, 70-year-old lady with low ejection fraction, who is scheduled for hip replacement. The decision regarding anesthesia, it requires careful consideration of her overall health status and the specific risk, as you mentioned, associated with anesthesia in her case. So definitely looking at this 34% ejection fraction, patient is not fit for anesthesia. But anyhow, we have to optimize and we have to give anesthesia to this patient. So there are certain risks associated with this patient. First of all, orthopedic case. As such, American College of Cardiology and American Heart Association classified orthopedic surgeries as an intermediate risk factor, risk surgery, because of the perioperative complication associated with this surgery, like perioperative loss, blood loss, heavy blood loss. And secondly, because of that arthritis, there are so many causes and that affect systemic, that has involvement of various systems. So we have to evaluate those systems. Secondly, with elderly patient, this risk is further increased, and there is increased chances of perioperative complication and mortality, because these elderly patients, they also have multiple medical comorbid conditions that we have to evaluate during our preoperative, that we have to keep in mind and evaluate during our preoperative assessment. Secondly, they have limited functional capacity in, so we have to evaluate what is the reserve which is already there. So we have to assess in that way. We have to assess the functional capacity of each and every organ in these patients. Then thirdly, because of diminished baroreceptor responses to fall in blood pressure and reduce inotropic and chronotropic response to both endogenous and exogenous catecholamines. So these patient has very low preventive measures in that to prevent low fall in blood pressure. Next is they have a risk of perioperative, as I mentioned, perioperative complication like in THR specifically, bone cement implantation syndrome, excessive blood loss, and thromboembolic phenomena are very common. And fourthly, the post-operative pain in orthopedic patient is very high, and we have to give high doses of this thing, analgesic, in order to give proper analgesia. That is important for early embolization. And cognitive impairment, that is also more common in elderly patient. So all these risk factors we have to evaluate. In top of that, these patient have, our patient has had this low ejection fraction, that is 34%. Ejection fraction it determines how well the heart is pumping out blood. It refers to percentage of the volume of blood that is pumped out of left ventricle and with each heartbeat. So as our patient has 34% ejection, means the systolic function of the heart is compromised. And these patients have higher risk of developing this thing, heart failure. And also because of they have a high risk of developing myocardial infarction, ischemia, dysrhythmias, and they may go into cardiac arrest anytime. So we have to take all the precautions so that patient won't end up in these problems. This low ejection fraction, usually of most of the time, it results from long-standing, poorly controlled hypertension, diabetic, or coronary artery disease. So we have to manage that. So our patient is elderly with combined risk of low ejection fraction and poor cardiac reserve, posted for orthopedic surgery. It presented multiple challenges to us on account of heightened risk of perioperative complication. So the patient fitness for, can we give this thing, can the patient be given anesthesia? It depends. We have to take combined decision of anesthesiologist, surgeon, and cardiologist. So what should be the type of anesthesia, what precaution we have to take during perioperative period, looking at the current health status and severity of our ejection fraction, low ejection fraction. Accordingly, we have to manage it.
So you mean to say the patient has to be taken for anesthesia,
Yeah.
and we have to decide what grade patient is belonging to. So what is the risk in this case, and we have to proceed accordingly, correct?
Yeah.
Okay, fine. Now my next question goes to Dr. Yogita. I want to know, should the following case be done in single sitting, or it has to be done in stages? What is your opinion regarding this?
Madam, as discussed by Dr. Pratibha, that this patient is elderly, 74-year lady with a
Huh.
low EF. So as such, the frailty score is coming on the higher side. Plus, cardiac condition with low EF, like around 35%, is a high risk category as per whatever revised Lee index or other whatever cardiac indexes we take into consideration for risk stratification. So she definitely comes into category of a high risk. So better to stage this procedure like one side at a time so that the surgical time is reduced, blood loss also intraoperative is reduced, and her overall surgical time, anesthesia time is also reduced. And post-op, we can take care of her in a better way. So I have of opinion that she should be staged and unilateral surgery should be taken into consideration first.
So by considering the patient's age and critical stage of the patient with comorbidities, it is better to do in stages rather than do it in a single sitting. Correct? This is what you want to say.
Yes, yes, ma'am.
Okay, fine. Now my next question goes to Dr. Pallavi. What investigation you feel should be done in this case for proceeding to undergo for anesthesia?
Yeah, so this we have this 74-year-old with limited EF. This surgery is kind of not an emergency, but time-sensitive surgery. Means we have to go ahead with the surgery. So, apart from the routine investigations, what we do, all the blood investigations and X-ray, ECG is must because this is a cardiac patient. And as for risk stratification also, we have to do the functional capacity, as Madam Pratibha said, that we have to assess the functional capacity of the patient. Clinically, we assess it by asking the effort tolerance, how the patient has, what effort tolerance he or she has. But to risk stratify, what is the risk? Also, risk stratification so for the management of the patient and to explain to the relatives of the patient that what is the risk of, major adverse cardiac events. So for that, we have to go ahead with some special evaluation, special test for these kind of cardiac patients. So we should have a 2D echo for all the findings which we will come to know on a 2D echo, regional motion wall abnormality. As she had a EF, if the 2D echo is very old, then we should ask for a fresh 2D echo. And now functional capacity, normally we'll ask for the exercise testing, like stress test. But in this patient who have this joint replacement, they have a limited mobility. So after a cardiologist reference, they might ask for a pharmacological stress test, that is dobutamine stress test. But that is also depending upon the patient's condition and how the patient will be capable of doing it or not. But that is only if the cardiologist is asking for it. Apart from that, clinically we have to assess what is the effort tolerance. And after that, the revascular, like this coronary, this CT angiography and all, also these are very, very specific and special investigations. These are also not advised, like we will not advise only after the patient is very, very high risk, and clinically she's looking very bad clinically, and the cardiologist advice, then only we'll go ahead. Otherwise, the 2D echo and pharmacological stress test, this can be the test which can be specific for these patients.
Okay, so if cardiologists feel that CT and CT angio or MRI has to be done, then this patient should undergo for those investigations. They are going to give us the clear-cut idea about the status of the heart or the functional status of the heart. Apart from that, any other investigation would you like to do in this case?
Like the for this is like a major blood loss and all surgery. If the cardio, like as madam said, all the organs should be tested for the functional capacity. We can go for lungs, we can ask PFT depending on the chest condition, and other organs will come to know by the lab investigations and all. So PFT you can ask, but cardiac wise, 2D echo and stress test will be helpful for risk stratification.
Bedside pulmonary function test can be done in this case if the patient
Yeah,
is
obviously, pulmonary
limited.
function clinically, whatever we are assessing the cardiopulmonary reserve from our obviously we cannot make the patient walk, so 6-minute walk test and all cannot be done. But breath holding time is a basic test we can do,
What
and
about
spirometer.
what
Yeah.
about the coagulation profile in this case?
Yeah, if the patients are like, depending if the patient is cardiac patient with stent and all, we have to ask the coagulation studies prior to we are giving anesthesia also. Mostly plan will be neuraxial technique, so we have to ask the coagulation studies for that. If the platelets and CBC and PTI, and if the patient was on DVT prophylaxis, like with the low molecular beta parin and all. So we should also rule out the timing of the dose and do this coagulation study preoperatively.
So frankly speaking, then apart from the routine investigation, we have to do the investigation which is related to the status of the heart and coagulation profile and the bedside pulmonary function test, correct?
Yes, yes.
Okay. Now my next question goes to Dr. Shilpa. What optimization is needed in view of psychological, pharmacological, and physiological status is concerned?
Yeah, so as Dr. Pratibha madam and Yogita madam said, these patients, we have already assessed their functional capacity. We have seen their frailty score. So now there's something called as prehabilitation. We need to have a team which will train these patients for exercise. It could be a muscle strengthening exercise. It could be a small form of aerobic exercises. Now, these exercises will help in the post-operative period, in early recovery. Also, there are two schools of thought. Some studies said that patients with low ejection fraction, like our patient, whether they should undergo this aerobic exercises. But Cochrane's study, which was done in 2010 and 2017, considering 33 RCTs, it says that this rehabilitation, muscle strengthening exercises and aerobic exercises, if they are used in controlled fashion, they definitely improve the ejection fraction and they increase the oxygen, peak oxygen consumption. So they should be advised. Also, along with that, as Pallavi madam said, for respiratory function, because post-operatively the patient might be in supine position for a longer time. So inspiratory muscle strengthening or training can be done. Then physiologically, if more than like you assess the nutrition of the patient. If the patient requires, then daily protein intake can be started if we feel that the protein intake is less or patient is malnourished. Regarding the pharmacological thing, first is these patients, as you said, madam, could be on a dual antiplatelet therapy. So whether to continue ecospirin on day of surgery or at least till 24 hours before surgery, it should be taken depending upon the coronary status of the patient. Then there is a beta blocker. The beta blockers, they should be continued until the day of surgery. They have definite evidence, a class 1 evidence that beta blockers should be continued in this patient. Regarding the ACE inhibitors and ARBs, some studies says that ACE inhibitors can cause hypotension, especially when we are giving regional to this patient. So they should be discontinued 24 hours. So there is no harm in discontinuing ACE inhibitors or ARBs, but they should be restarted, especially as Dr. Pratibha madam had said, if the low ejection fraction is because of systolic dysfunction, then continuing ACE inhibitor could be advisable on day of surgery also. Then some patients might be on alpha-2 agonist. Then some patients might be on evabrad. So all should be continued till day of surgery. We should only take care that intraoperative hypotension and bradycardia should be avoided. Regarding the psychological support, these patients are likely to go post-operative or likely to undergo post-operative cognitive dysfunction. So their daily activity should be assessed pre-operatively. And we should ask them if they require any psychological support. And in this way, like we should be managing the patient as an entire pre-operative training of the muscles, plus the drug therapy and plus the psychological therapy.
Okay, so you mean to say regarding psychological concern is concern that patient is a geriatric patient. So psychologically, we have to keep her elevated mood, elevated mood, and we should find out what is the exact status of the psychological condition, so we can just compare in post-operative period. So patient should not get deteriorated. Regarding pharmacological concern is concerned, then we have to continue all the medications whichever the patient is receiving. And see, there are very few medications which we have to stop it for pre-operative period for few times. Otherwise, all the medications has to be continued. And regarding psychological aspect and cognitive function, if we know what is the preoperative condition of the patient, it is better for us to how the management will go in the post-operative period. So frailty status is also going to help us in managing the patient or planning the anesthesia for these patients. Correct?
Yes, ma'am.
Okay, fine. Now, my next question, any panelist can take it. I just want to know how you are going to optimize the patient in view of low ejection fraction and what should be done for optimization in this case, in this particular case. Dr. Yogita?
The way Pratibha ma'am has mentioned initially, she is a 74-year-old lady. Probably we have to ascertain the cause of low EF in this lady. Either it is post-myocardial infarction or it's a pre-existing cardiomyopathy or some other cardiac illness leading to this low EF. So depending on the original cause of low EF, if that lady is having myocardial infarction, the drugs for maintaining the contractility of the heart, like generally ramipril or beta blockers, which are rate control drug, or if at all calcium channel blockers has been added for better rate control, those medications has to be continued in the perioperative period. And if other reasons of low EF are there, like cardiomyopathy, there is person or definitive treatment for that. But if some supporting devices are in place, those devices are functioning well. If pacemakers are there, so that pacemaker leads are in place, the warranty period is in place, the technician is available during the perioperative period. All these things we have to ascertain before we start the case. And functionality of all this has to be confirmed with cardiology department before we post such patient.
Dr. Pallavi, would you like to add?
Yeah, the improving EF, as Yogita said, we have to take steps according to the cause of why the EF is low. But all the medications, if sometimes the patients come with irregular treatment and also we might have to take advice of our cardiologist friends and what all the medication she should be taking. If the chest wise she's bad, then we have to do the chest therapy to optimize her lung function. All the drugs, as Shilpa ma'am said, that has to be continued. If these joint patients might not be, mobile, so they might not be like other patients who can, improve their exercise tolerance and all. But bedside, whatever we can do, and what cardiac wise, whatever drugs she is on, antihypertensives, or she's diabetic, then the blood sugar should be controlled. So maybe she has to take insulin perioperatively. So sugars also should be controlled. So all these things should be taken care to improve her cardiac status perioperatively to have a better outcome.
Dr. Pratibha, would you like to add something?
Yes, madam. Besides all this thing, if suppose patient is having this thing, sign and symptoms of heart failure, that also leads to again fallen low ejection fraction. So in that case, we have to give anti-failure. We have to continue with diuretics, and we have to give anti-failure medication like digoxin and other to support the myocardial contractility, levetiracetam and other inotropic drug we have to give. That's how, and you have to well control the hypertension and diabetes if it is associated. So diuretic should be keep in mind. And while giving diuretic, you have to be careful about the electrolytes.
So basically, we have to find out what is the cause of low ejection fraction in this case, and accordingly, we have to treat. The patient may be symptomatic with low ejection fraction or may be asymptomatic. Many a time the ejection fraction is low, but patients are asymptomatic. So in that case, we have to find out the cause and treat accordingly. Most of the time, these cases are on diuretics, then on anti-failure treatment or in antiarrhythmic drugs. So we have to continue all those drugs. And if the patient is receiving these drugs, then we have to take care of the electrolytes also. Because if the patient is receiving electrolyte, then electrolyte imbalance is there. There are the potassium disturbances. So all those things has to be taken into consideration. And because of the stress of the surgery and the stress of the disease, their blood sugar levels fluctuates very, frequently and very drastically. So we have to monitor the blood sugars also in these type of the cases. So it will give you idea how much stress patient is getting because of the planning of anesthesia, planning of the surgery is concerned. So find out what is the cause, find out whether the patient is symptomatic or asymptomatic, what drug patient is receiving, and what investigations we have to do it as per those drugs are concerned. Right? So these are the points we have to keep it in our mind before planning the anesthesia in this case. Now, my next question goes to Dr. Gedhoo. As sir is managing pain, he's a pain physician and he takes care of the all sorts of the pain, acute pain, chronic pain. So and he has undergone for surgery recently. So he, as a patient also, he has, come across with the pain management and pain factor. So I would like to know from you, what is the choice of anesthesia? What are the advantages and disadvantages of your choice? And can general anesthesia be given to this patient? There are 3 questions for you, sir, in one question.
Okay, done. See, madam, first thing is, as if the patient is absolutely asymptomatic and plus she is just 74 plus years age. So we cannot just wait for a very long time for us to improve her ejection fractions and all those things. I agree we can continue the medications and all. But then again, if she is asymptomatic, she is not in signs of failure or arrhythmia or something, then I think we can plan surgery, of course, anesthesia. In anesthesia, again, with such a thing, of course, unless the PT-INR is under control. If I find the PT-INR is okay, platelet count is fine, then I don't mind going into the epidural anesthesia. If that is not there, in such a condition, PT-INR is a bit disturbed, then I don't mind going into, there are some certain blocks are there, which can be practiced for a unilateral surgery also, like Peng blocks and all those things. That can be given. Or else, even GA can be planned. It is not that it, I mean, at least I never postpone such patients also, even if there is a 34% ejection fraction. I don't mind giving anesthesia, though it will be, I have to maintain more of the analgesic instead of giving a anesthetic drugs.
So what is your
Like,
choice of anesthesia, regional or general?
ideally regional.
So you would
Ideally
like
regional.
to give regional anesthesia to this patient.
Yes.
How much time you think that optimization time can be considered for this case?
Optimization of cardiac symptom. Madam, at see 34% ejection fraction, and even if you want to give any other analgesic or not analgesic, cardiac drugs or whatever it is, it will not be that it is just within 15 days your 34 will become 44. It is not
So
that easy because she's an old lady.
What I mean to say, if the patient is
And
receiving...
she's such an old lady that we cannot just sustain for a long time. You never know, she may just go.
So you would like to take this case immediately, you mean?
Yes, I don't mind going immediately.
But if the patient is receiving aspirin or clopidogrel type of the drugs, then would you like to wait for some time, or you would like to take the
No,
patient?
see, if it is aspirin, aspirin has got no problem even if I want to give spinal or epidural or any regional. But if it is clopidogrel or enoxaparin, then I may have to wait for 48 hours to maybe 3-4 days. Thereafter, I will repeat the PT-INR and thereafter I can plan for anesthesia.
So if the
stop all those things, clopidogrel and all those things.
If the aspirin is going in low doses, 75 milligram per day, then we don't mind giving the case immediately.
Yes, doesn't matter.
But this case is going to be as an elective case, right? So would you like to give some more time for clopidogrel and all other antiplatelet?
As I told you, madam, if it is clopidogrel and your PT-INR have been distorted already, in such a condition, I will wait for at least 5 days minimum by stopping the clopidogrel or any other thing, enoxaparin. Then, but if the patient is on ecosprin or heparin, also low dose heparin, in such condition, I don't mind. I just wait for 6 hours. After 6 hours, I can plan my regional anesthesia.
What about general anesthesia? Can we give general anesthesia to this case?
Yes, 100%. I will give.
So what are the precautions we have to take if we are planning to give general anesthesia? Patient is refusing.
As I told you, patient apart from 34% is asymptomatic. Unless, as Pratibha has rightly said, if she is patient, there are signs of failure, that's a different story. But if there are no signs of failure, then even if your ejection fraction is 34, I will have to give anesthesia.
So if you are
I cannot just keep on postponing the patient for these reasons.
If you are planning to give general anesthesia, then which drug you would like to choose for induction of anesthesia?
Of course, I won't go for a propofol. I will prefer to go for unless patient has got some respiratory problem, that's a different story. Otherwise, I don't mind going for a thiopentol. I will induce with thiopentol instead of propofol. And as far as inhalation is concerned, I will not prefer to give much dose of inhalation. Maybe I will give isoflurane, but again in the very low doses. But instead, I will prefer more the analgesics, like fentanyl or all the relaxants and all.
What about etomidate, sir?
Etomidate is also fine because it's a cardiostable drug, most easy. I agree, but it's not been routinely available. But if it is available, I will prefer etomidate definitely.
Which muscle relaxant would you like to use?
I don't mind going for either vecuronium, because I will not prefer atracurium, because atracurium can produce sometimes bronchospasm or some allergic reactions also. I will not go for that. I may prefer either pancuronium or because pancuronium is not available today, vecuronium I will go.
So vecuronium or rocuronium is the preferred.
Rocuronium also I don't mind. That's what I said. I don't mind.
Okay, thank you, sir. My next question goes to Dr. Pratibha. What are the expected hazards intraoperatively in relation to use of cement is concerned?
because this cement may lead to, there may be a chances of minor to major complication will be there. That can be, there can be a bone cement implantation syndrome. There can be a cement leakage, can be this thermal injury, or this can lead to this thing, allergic reaction. So depending on this, what is the percentage, as such the bone contains powder, there is a powder and a solution. So the orthopedician mix that powder and that solution. Powder contains polymorphic, this methyl methacrylate, and the solution contains monomer of methyl acrylate. So when they mix that, after mixing, there is an exothermic reaction. So it gets hardened, that cement gets hardened. The exact cause of the bone cement implantation syndrome is not known, but there is a wide range. It can lead to hypotension, mild hypotension, to a severe cardiac arrest. So it's a wide range of clinical symptoms related to this, and pathophysiology is still unclear. But because of this exothermic reaction and hardening, there is sudden increase in intramedullary pressure, and that forces fat, air, and other things into the femoral circulation, into the venous circulation, and that leads to thromboembolic phenomena. And second thing is, because of that monomer may activate inflammatory response, and that activates platelet aggregation, and that cause endothelial damage and leads to systemic inflammatory response. So both these are the two most commonly acknowledge this phenomena for that are responsible for bone cement implantation syndrome. And there are certain risk factor, maybe patient related or surgery related. We should keep those things in mind. So patient related, especially obese patient, and also surgery related, like in cases of intertrochanteric fracture. Intertrochanteric fracture in which there is no pre-instrumentation of that medullary canal. And secondly, if a surgeon is using long femoral component, then there is high risk of the cement implantation syndrome. So for prevention of that, they can the surgeon can put a drill at the lower end of the femur, so that it won't cause too much pressure to be generated inside that femoral medullary canal. That's the main preventive precaution they can do. Then secondly, from our point of view, we have to promptly recognize this syndrome and act accordingly. And we have to analyze the risk. And suppose this happens, then you have to give 100% oxygen. If patient is under general anesthesia, then stop nitrous oxide and give 100% oxygen. And according to the patient condition, we have to manage. Right? Like there are three grades of bone cement implantation syndrome according to the saturation level, fall in blood pressure, and the consciousness of the patient. So grade 1 is when the saturation is less than 94%, and the blood pressure, fall in blood pressure is more than 20%, and patient is conscious. In that case, we just have to give oxygen and manage that fall in blood pressure with vasopressors. And second degree is when the saturation is less than 88%, and the fall in blood pressure is more than 40% of the baseline. And at this level, patient is still conscious. And so in that case, we have to again manage give more vasopressor and give oxygenate with positive pressure. We have to give more oxygen. And third grade is where the fall in blood pressure, patient is totally uncompromised. There's no pulse and nothing. So we have to give cardiopulmonary resuscitation in that case. So according to the patient condition, we have to manage it. Second complication is that cement leakage. So that is the job of orthopedician. They have to be careful while mixing. According to the exact percentage, they have to mix it, and then carefully they have to implant that thing. Third is that exothermic reaction. So that causes necrosis and charring of the surrounding tissues. So according to the grade of that charring and this thing, that can be managed. If it is mild, then they can just observe and this thing. If it is major chairing, then they have to do debridement and other thing. In cases of allergic reaction, then we have to give antihistaminics and other medication and to manage that allergic reaction.
Can we do some prophylactic measures for prevention of all these problems are concerned?
Yes, madam. As I said, that there are many risk factors. So we have to promptly recognize those patient and related and surgery related risk factors. And then carefully we have to prepare this, ask the surgeon to prepare it carefully, that cement mixture. And meticulous surgical technique is important. And surgeon has to drill at the lower end so that there won't be a major generation of that intramedullary pressure. Then we have to continuously monitor the patient vitals, and after cementing we have just if we detect, then we have to manage it. And I said FiO2 should be, we have to keep 100%, and and we have to give blood volume, we have to maintain the intravascular volume status.
So you mean to say good analgesia and hemodynamic maintenance has to be done carefully during cementing is concerned.
And 100% oxygen.
100% oxygen. Okay.
And continuous vital monitoring.
Okay.
So that we have to detect it promptly and manage it.
Now my next question goes to Dr. Pallavi. Is there any role of steroids in this situation?
Ma'am, steroids in arthroplasty is basically the advantages of using steroids will be as an analgesic for post-op pain. Also, they can be helpful for reducing the post-op nausea, vomiting. And there has been studies done which have shown that they have reduced the opioid consumption post-operatively. But there has been studies, but the people are scared of using, like we are worried about like increase in the sugar levels, and which can lead to wound site infection because of the increase if there is a blood sugar level high. So, but if we see the literature, there is limited literature about the cases or the studies showing the complications because of steroids. So also there are limited studies how much is the dose to be given of steroid perioperatively, whether 4 mg IV or 8 mg IV. Also whether the single dose of steroid or multiple doses of steroid should be given. Less studies are evident in the literature because people have not used in the diabetic patients because of risk of increased blood glucose levels. But yes, there are some evidence that it helps to reduce the post-op pain, post-op nausea, vomiting, and opioid consumption. But obviously, the more studies in future are required. Some of the centers, or in olden days, methylprednisolone used to be given as in the cases of cementing. Whether before giving if there is a cemented arthroplasty, we used to give methylprednisolone. But there is a controversial things about the use of steroids. But we can use dexamethasone 4 mg IV or 8 mg IV. Avoid in a diabetic patients.
No, but as per endocrinologists are concerned, they are saying if the patient is diabetic also, and if such kind of the reaction has happened or is going to happen, then single dose steroids can be used safely. There is no harm.
Absolutely.
And if you see the level of blood sugars after giving the steroid, it doesn't rise so much. So single dose can be used safely without thinking much if the reaction occurs because of the cement.
Yes.
And as Pratibha has already said, that chances of pulmonary embolism is there. And if pulmonary embolism occurs, then we have to treat the pulmonary embolism by giving 100% oxygen, intubating the patient immediately, keeping the patient's hemodynamic as much as possible in the stable condition. Vasopressors can also be used. IV fluid also can be given safely, and then choice of IV fluid is more important in this situation because the patient is having low ejection fraction and heart status is not that good. Okay, so now my next question goes to Dr. Shilpa in this regard. What is the choice of fluid you would like to give in this case? What is the role of the blood and blood products?
Yes, sir. In this case, as everyone said, We usually think that fluid should be very much restricted with low ejection fraction. It should be restricted, but these patients also depend upon the end diastolic volume, which is present in the heart. So at least if we are doing a hip arthroplasty, 5 to 6 ml per kg baseline fluid should be given. Of course, we'll have a central line in place and if possible an arterial line. But it is better to give fluids and I would prefer crystalloids such as balanced salt solution or maybe plasmalide, which is there nowadays. I would avoid dextrans, which now have been proven to have can cause renal injury, especially elderly patient. And regarding normal saline also, they have said that if you exceed 1 liter, it can cause hypochloremic kidney injury. And regarding blood products, initially what we learned that in cardiac compromised patients, the hemoglobin should be at least 10 gram percent and with hematocrit of 30. But the recent guidelines say that even 8 gram percent to some studies say that 9 gram percent of hemoglobin is acceptable in cardiac compromised patients. Now, if the patient hemoglobin is less and if we have time, like it is a relatively not an it's a semi-emergency surgery. If we have time, then we can give IV iron along with folic acid and B complex. Some studies say that you can also try giving erythropoietin, but we have not heard of anyone giving erythropoietin, maybe IV iron and B complex. Regarding the cell saver technique, which had come in between around 10 years back, it was very much in use. So if you're expecting a blood loss more, like in this case, hip arthroplasty, we can use a cell saver technique if you're expecting more than 20% of the blood volume. Regarding if you want a preoperative autologous donation, like if the hemoglobin is around 9 to 10 gram percent, and you want to remove blood preoperatively, initially that was also considered, but they say that it gives cost as well as infection. So it is better to avoid. Regarding on table also, you can have autologous transfusion where you remove the blood and give it to the patient so that you have control over the hypotension and the anemia which is occurring once you remove the blood. That's it. I think blood should be replaced with blood and more of crystalloids and plasmalide should be used, balanced salt solution. And the threshold has been to 9 gram percent. If you have time, buy it with hematinics.
So you mean to say the restricted fluid has to be given. The choice of fluid will be combination of colloid and crystalloid like plasmalide. Blood has to be replaced with blood. And if the patient is on anticoagulant or antiplatelet drug, then chances of bleeding will be more. So then blood product should be considered. And as we have decided to give the regional anesthesia to this patient, so co-loading has to be done rather than doing the preloading to this patient. Correct? This is what you want to say. Okay, fine. Now, my next question goes to Dr. Yogita. What are the possible cardiac and pulmonary complications can occur on table in this case, and how you are going to manage them?
Since this lady is already a low EF patient, around 34% EF, so possibility of going into failure is very high. So we have to be very careful in giving fluid and blood product replacement if at all it is required. So overloading possibility always has to be kept in mind. Second thing is because of regional, there are sometimes possibility of hypotension which may not be controlled. So because of hypotension, possibility of myocardial infarction also increases if we cannot maintain that hemodynamics around 20%. So ECG changes, whether diabetic, non-diabetic, depending on that, whatever ST elevation or non-ST elevation, ECG changes are very possible and commonest thing to happen intraoperative as well as in the perioperative period. And because of low EF, again, dysarrhythmias are very common in the intraoperative as well as postoperative period. So these are the most common complication as anesthetist we come across with such category of patients. So all these factor has to be kept in mind before the procedure is started. all antiarrhythmic agents has to be in place. Availability has to be confirmed before starting the case. And we have to be very meticulous. As Dr. Shilpa said, if required, we can put a central line. And if we are feeling that arterial line is required, even arterial line can be placed so that we can handle the hypotension or sudden blood loss or even bone cement implant syndrome that also leads to arrhythmias later on. So all these things we can control in a better way. So these are the commonest complications as a cardiac complication we come across in such category of patients.
So you mean to say if this patient is having low ejection fraction and cardiac problem, then we should be ready by keeping all the cardiac drugs on our trolley, like all vasodilator drug, vasopressor drugs, and antiarrhythmic drugs, and all miscellaneous supportive drugs, whichever is required for dealing with the cardiac complications are concerned. And if patient is going to get the pulmonary complications, then immediately intubation has to be done. 100% oxygenation should be given to the patient. And what should be the ventilator strategy? We have to intubate the patient and keep the patient on ventilator if lung complication occurs.
If at all we come across lung complication, lung protective strategies has to be in place. 6 to 8 ml of tidal volume has to be set. Any mode is okay, volume control or pressure control. But if as such pre-existing pressures are very high, we can have that volume control and pressure guaranteed ventilation, which will give us better control. And that pressure control will not lead to further fall in blood pressure. So these strategy PEEP depending on the like 6 to 8 millimeter is the safe PEEP we can apply if we are coming across pulmonary complication. Better not to exceed more than 8 millimeter PEEP. So these are the ventilator strategies which will help us in better oxygenation, and slowly over a period of time things will settle down if patient is progressing in the right direction. So lung protective ventilatory strategies has to be in place after intubation if at all we are requiring intubation in such kind of patients.
So you mean to say low tidal volume, high rate, and volume control is preferred in these cases if the lung injury has occurred intraoperatively, correct? With 100% oxygen.
And as Madam has said, FiO2 has to be changed to 100% and nitrous has to be switched off, or if possible, air can be mixed depending on oxygenation of the patient.
I would like to ask you one more question here. Everything has gone very smoothly. Dr. Gedhoo has no problem in giving general anesthesia to this patient, and the surgery has went very smoothly. Management has done quite all right. Now you have to reverse this case. So which drug you would like to use it for reversal of this case after giving general anesthesia?
Conventionally, we always use glycopyrrolate and neostigmine because slowly, if they are given ages of experience, we all have with this reversal agent. So I will stick to glycopyrrolate and neostigmine. Neostigmine dose should not be crossed. Only thing that 2.5 milligram or 0.5 milligram per kg should not be crossed. So adequate neostigmine dose should be all right for reversal. And the last top-up time should be kept in mind before reversal so that we avoid any delayed recovery in the post-operative period.
What is your opinion regarding Sugamadex in this case, in this particular case?
Yeah, this is a very elective case, and if everything is going fine, and even though everything is not going in the right direction, so we will be obviously skeptical in extubating this patient. So I don't think Sugamadex I'll be happy to use unless really some emergency situation is happening. Otherwise, if doses are kept in mind, my last top-up dose is kept in mind, I'll be happy to reverse with glycopyrrolate and neostigmine. But any unforced scenario, Sugamadex can be implemented. But otherwise, because we know the timing of the procedure, my last top-up will be the guiding decision for me.
Dr. Pratibha, would you like to comment on this point?
I think, Madam Doctor, as whatever Dr. Yogita has said is absolutely right. We are comfortable with glycopyrrolate and neostigmine. So in this critical patients, we have to go with whatever drug we are comfortable with, rather than trying for new drug. I will also go for glycopyrrolate and
Okay, fine. I differ here from your both of your point of view because I'm using Sugamadex quite regularly in my institute nowadays. And after doing all lung surgeries, we are giving Sugamadex for reversal. The only thing which we have to keep it in our mind that vecuronium last dose when it has been given and attempt should be there. And if attempt has come properly, then you can give Sugamadex in the doses of 4 milligram per kg body weight. Instant, there is no need of giving glycopyrrolate or atropine with the Sugamadex, and it really helps. It really helps, and patients are instantly out. So you can try if you get the chance to use it. That is not very easily available, but if you get the chance and if you have the drugs, then you can try it in this case also. So especially when we are dealing with the lung problems, then I'm in doubt if the problems are not because of the lung or because of some other thing. Then I use the Sugamadex in this case. I would like to use it, ma'am. Okay. Now, next question goes to Dr. Gedhoo again. What is the strategies of post-operative pain management in this case?
Madam, it all depends whether we are given GA and plus regional also. But anyway, if GA is being given, then I don't mind going for a regional block, that is either PENG block or something like that. If, of course, patient's PT-INR and everything has been fine, then I don't mind giving the epidural also, so that epidural can be continued for 5 to 7 days post-operatively also for the pain management. It depends what patient's PT-INR status is there and other status is there.
So if PT-INR status is all right and we have preferred to give regional anesthesia to this case, then you would like to continue with the epidural.
Yes.
Would you
Can
like
be
to
continued
add,
for 5 days.
would you
Can be
like to
continued.
add some other drug in this case with epidural?
Yeah, we can add the analgesics also, like fentanyl also I can add in that.
No, bupivacaine and fentanyl is a regular and common
Yes.
common drug which we are
Yes.
using it.
Yes.
But I mean to say, would you like to give the multimodal analgesia to this case in the form of giving paracetamol or fentanyl patch?
Paracetamol is okay. Fentanyl patch I will not accept. Never accept, because though it is being stated many people are using, but fentanyl patch is not supposed to be used for the acute pain management. Because the minute you are being operated today and I put a fentanyl patch to you, your temperature and all those things rise, so that the chances of absorption of the fentanyl are very high. So honestly, it is not been recommended for any post-surgical or acute pain. It is recommended only for a chronic pain.
So epidural with bupivacaine and fentanyl.
Or I
And
can even go for
paracetamol.
yeah.
What about patient-controlled analgesia?
See, if it is epidural, it is not being given because patient's PT-INR and all those things are being disturbed. In that condition, I don't mind going for a PC also, patient-controlled analgesia. Patient-controlled analgesia can be both way. Patient-controlled epidural analgesia is also there. We have got option, or patient can have his own option also.
So which drug you would like to give for patient-controlled analgesia?
See, in this condition, again, as I told you, fentanyl is the only preferred as far as IV is concerned, because it is a patient-controlled analgesia, not epidural. So there is no local anesthetic to be added. So I will go for this.
You will go up with the fentanyl.
Yes.
What about morphine, sir?
Morphine, madam, will cause a lot of respiratory depression, and in a patient who has been already compromised with a ejection fraction, so naturally respiration will not be also very good. So I will not go for a morphine at all.
But even with the adjustment of doses also, you will not prefer to give morphine?
No, never.
Okay.
I'll prefer to go with a fentanyl only.
Okay, so multimodal analgesia in the form of epidural and paracetamol, and if required, the additional doses of fentanyl, correct?
Yes.
Okay, fine. Thank you, sir. Now, my next question goes to Dr. Pratibha. What is the recommendation of physiotherapy?
Yes, madam. As we all know, the elderly patient who is hospitalized have persistently poor outcome and delayed recovery, irrespective of the ejection fraction, irrespective of the type of surgery, because of the impairment of physical function. Secondly, because of impairment of cognition function, mood, and quality of life. And that is why physiotherapy and also the cognitive function, care of the cognitive function is must for this elderly patient. And especially in this low ejection fraction patient, the exercise tolerance is already
Compromised.
compromised, and so there is a strong determinant that strongly reduces the quality of life. So it is very important, especially in this case, elderly with low ejection fraction, the exercise training that will improve exercise tolerance and quality of life in this patient. But keep in mind the compromised cardiac status of the patient. In that case, a well-organized physiotherapy is definitely effective in reducing pain, improving muscular performance, and that will help in early mobilization. And thus, it will improve functional independence and quality of life all. And it all further facilitate early recovery, and it reduces the risk of thromboembolic phenomena, even pneumonitis and DVT. So the preoperative, as Dr. Shilpa has mentioned about the preoperative counseling, so we have to start with preoperative counseling of the patient and family members about the importance of physiotherapy, in particularly in this elderly age group with low ejection fraction. And we have to tell about the outcome, potential limitation, and what they have to do in post-operative this thing period. So it will start with implementation of passive and active motion exercises of the hip joint, and that will maintain the flexibility and prevent the stiffness of the joint. And further, we can increase the intensity and duration of that thing. And after that, when we think that patient cardiac status is okay, then we can apply a strengthening exercises of the hip muscles around the hip joint. And after some time, balance and gait exercises. This will definitely help in early mobilization and improving this quality of life and tolerance, exercise tolerance of this patient. And besides this, we can also advise this ice therapy, heat therapy, and TENS that will reduces the post-operative analgesic requirement. So that can be used.
Yes, I'm fully agreeing with you regarding use of ice. Ice really helps the patients in reducing the pain and requirement of the analgesic drugs are concerned. It is really very helpful. And regarding cognitive function, if you know the preoperative status, then you can take care of the cognitive function in the post-operative period also. Preoperative static exercises and physiotherapy will definitely help in post-operative management of the physiotherapy is concerned. Static exercises really helps. So these are the things we have to keep it in our mind before dealing with such kind of the patients. And all the medications which are given for the heart status is concerned has to be continued during the intraoperative period and even the post-operative period, right? So to conclude this case, I would like to say the anesthesia has to be given. We can't say that I'm not going to give anesthesia. Second thing, case should be given in stages because single stage, one stage patient will not able to tolerate the bilateral hip surgery because elderly patient ejection fraction is low and having the, that geriatric all problems. So it is supposed to be done in stages rather than doing in single stage. Apart from routine investigation, advanced investigations, specific investigations to be done, which we have already discussed in relation to coagulation profile, in relation to bedside investigation, pulmonary function test, in relation to cardiac status, even cardiac CT angio also helps, right? So we can do those investigations. Now regarding cardiac monitoring, that advanced monitoring in the form of cerebral oximetry will help you in managing the cognitive function during intraoperative period. Then nutrition, pharmacological optimization and counseling of the patient to be done. Then regional anesthesia is a preferred anesthesia for all such sort of the patients, even if the patient is a known case of cardiomyopathy. Then preventive measures for cementing should be taken care. Consider the combination of crystalloid and colloid, as Shilpa has already said it. Blood and blood products should be considered and should be taken into consideration as and when needed. Respiratory and cardio complications are well known, so you should be ready to diagnose early and treat them intraoperatively. During this surgery, care must be taken. Multimodal analgesia for pain management. Physiotherapy is must, and non-narcotic analgesics should be considered for the cognitive care in this case. So this is to be concluded. And I think all of us has done the good job regarding discussing this case. So now the mic I'm handing over to Dr. Radhakrishna or Jayasree Madam, whoever is there. Madam is there, I can see the madam to conclude the session.
Thank you, Manjula, for giving me this opportunity. I'm extremely thankful to Manjula and the whole team today for moderating and conducting a panel discussion on such an important topic, and a topic that is often we see these kind of patients in our practice. So this has been taken, it's nothing uncommon. And for the students, of course, it's very important because all the questions which are asked in the exam were covered by Manjula and her team. And also that for the faculty, the youngsters who do these cases in their practice, I think all the points were very, very valid. So thanks a lot. Thank you so much, Manjula, Dr. Gedhoo, and all the speakers who were there. Thank you so much, Pratibha, Yogita. Thanks a lot. And we'll see you all next Wednesday. We'll see everybody next Wednesday and you as faculty in the near future. Thank you so much. And please, as I said, save the dates for the ICA annual conference, PG assembly, because they'll all be benefited. Thank you so much and good night.
Thank you. Good
Thank
night,
you.
madam.
Thank you, madam.
Radha, you want to say something?
Shilpa, good night.
Radha there.
Yeah, good night.
Suddenly disappeared.
Thanks, Rupsa.
I think Dr. Radhakrishna wants to say something.
Yes,
I
of
saw him,
course.
but he disappeared.
Okay, so we can leave now.
Thank you, everyone.
Thank you. Good
Thank
night.
you for the
Thank you.
opportunity.
Thank you.
Yeah,
Bye, bye, everybody.
Thank you, Manjula.
Thanks.
Good night.
Thank you
Thank
so
you,
much,
madam.
everyone.
Manju, madam.
Thank
Sue,
you.
madam.
Bye-bye.
And thank you
Thank
all.
you so much for extending us the opportunity to host the session. So with all your permission, I would like to conclude over here. Thank you. Good night.
Thank you. Good night.
Thank you.